This video is on bronchiolitis. Recommendations for diagnosis, monitoring, and the management of children 1 to 24 months of age with bronchiolitis according to AAP and the Canadian Pediatric Society. Bronchiolitis is a viral lower respiratory tract infection characterized by obstruction of small airways. This is caused by acute inflammation, edema, and the necrosis of epithelial cells lining the small airways, as well as increased mucus production. Respiratory syncytial virus or RSV is responsible for most cases of bronchiolitis. However, other viruses including human metapneumovirus, influenza, rhinovirus, adenovirus, parainfluenza virus can all cause a similar clinical picture. Co-infection with multiple viruses occurs in 10 to 30% of young hospitalized children. Primary infection does not confer protective immunity, and reinfection continues to occur into adulthood. But with repeated infection, it being generally milder. Bronchiolitis affects more than 1/3 of children the first 2 years of life, and it's the most common cause of hospitalization less than 1 year of age. Bronchiolitis is a clinical diagnosis based on a direct history and a physical examination. It may present with a wide range of symptoms and severity, from a mild lower respiratory tract infection to impending respiratory failure. Bronchiolitis typically presents with a first episode of wheezing before the age of 2 years. The course begins with a 2 to 3 day viral prodrome of fever, cough, and rhinorrhea, progressing to tachypnea, wheeze, crackles, and a variable degree of respiratory distress. Signs of respiratory distress might include grunting, nasal flaring, indrawing, retraction, or abdominal breathing. There may or may not be history of exposure to an individual with a viral upper respiratory tract infection. Overall, the typical illness of bronchiolitis begins with upper respiratory tract symptoms, followed by lower respiratory tract signs symptoms on day 23, which peak on day 3 to 5 and then gradually resolve. So the peak time of severity is on the day 3 to 5 after signs and symptoms of lower respiratory tract signs appears. So we should have to ask preceding viral upper respiratory tract infections, cough or rhinorrhea, when we evaluate a child with suspected bronchiolitis, and exposure to an individual with viral upper respiratory tract infection. And also we should have to check for signs of respiratory distress, tachypnea, intercostal subcostal retraction, accessory muscle use, nasal flaring, grunting, color change, apnea, wheezing or crackles, and saturation level. Physical examination findings of importance includes increased respiratory rate, signs of respiratory distress, and crackles and wheezing on auscultation. And also decreased saturation level is very important to decide for inpatient management. Signs of dehydration might be present if respiratory distress has been sufficient to interfere with feeding or if there is associated vomiting. In addition to viral bronchiolitis, differential diagnosis for wheezing in young children include asthma, other pulmonary infections such as pneumonia, laryngotracheomalacia, foreign body aspiration, gastroesophageal reflux, CHF, vascular ring, allergic reaction, and other problems such as mediastinal mass and tracheoesophageal fistula. So we should have to rule out them by history and the physical examination. When we came to investigations, diagnostic studies are not indicated for most children with bronchiolitis. Tests are often unhelpful and can lead to unnecessary admission, further testing, and ineffective therapies. Chest X-ray of infants with bronchiolitis often reveals non-specific, patchy upper inflation in the areas of atelectasis. These areas of atelectasis might be misinterpreted as consolidation, and it might lead us to give antibiotics despite absence of bacterial infection. So chest X-ray is not needed most of the time. While routine chest X-ray is not supported by current evidence, chest X-ray should be considered when the diagnosis of bronchiolitis is unclear, when the rate of improvement is not as expected, or severity of disease rises, other diagnostic problems such as bacterial pneumonia. In this case, we should have to do chest X-ray. Nasopharyngeal swabs for respiratory virus generally are not helpful for diagnostic perspectives and do not alter management in most cases. CBC has not been found to be useful in predicting serious bacterial infection, and bacterial cultures is not needed because the incidence of concomitant uh, serious bacterial infection in febrile infantis with bronchiolitis is low, so doing the culture is unnecessary. There are a group of children that are at high risk for severe disease. Those includes infants born prematurely, those infants less than 3 months of age at presentation, and those infants in whom hemodynamically significant cardiopulmonary disease are present, and immunodeficient children. Criteria to admit an infant with bronchiolitis to hospital for inpatient care include signs of severe respiratory distress, supplemental oxygen required to keep saturation more than 90%, dehydration or history of poor fluid intake, cyanosis or history of apnea, infant at high risk for severe disease as we mentioned above, and family unable to cope with the problem. Let's see the management overview of an infant diagnosed to have a bronchiolitis. Bronchiolitis is a self-limiting disease. Most children have mild disease and can be managed with supportive care at home. For those requiring admission, supportive care with assisted feeding, minimal handling, gentle nasal suction, and oxygen therapy still forms the mainstay of treatment. Therapies that are recommended based on evidence, according to AAP and the Canadian Pediatric Society. Those therapies include the first one is oxygen. Supplemental oxygen therapy is the mainstay of treatment in hospital. Oxygen should be administered if saturation falls below 90% and used to maintain saturation more than 90%. To minimize handling, oxygen is usually administered via nasal cannula, face mask, or head box. Heated, humidified, high-flow nasal cannula oxygen therapy can be given for those who are in severe distress. There is increasing evidence this mode of non-invasive respiratory support, that means high-flow nasal cannula, may reduce the need for CPAP and the mechanical ventilation in moderate to severe bronchiolitis. The other therapy that is recommended is hydration. Frequent feed should be encouraged and the breastfeeding supported. Infant with a respiratory rate more than 60 breaths per minute, particularly those with nasal congestion, might have an increased risk of aspiration and may not be safe to feed orally. When supplemental fluids are required, NG2 feeding and intravenous routes be equally effective. On a large studies, evidence that shows equivocal importance include epinephrine nebulization, nasal suctioning, and the combined epinephrine and the dexamethasone. But we should have to try epinephrine, and if the child is responding, we should have to continue, and if it's not responding, we should have to discontinue. Therapies that are not recommended include salbutamol, use of steroids, antibiotics, antivirals, chest physiotherapy, and hypertonic saline. So, as a summary of management, the following are not shown to be effective in the emergency department treatment of bronchiolitis. Use of salbutamol, use of bronchodilators, ipratropium bromides, hypertonic salines, inhaled corticosteroids, systemic corticosteroids, and the antibiotics. So, most of the time, they are not recommended. We do not use them. Thank you for watching.